Hello, everyone, and welcome to the Determinants of Her Health podcast, where we examine the systems that affect women's health and how we can shape them. Today, I have with me Dr. David D. Clarke, MD. He is the president of the Association for Treatment of Neuroplastic Symptoms, symptomatic.me. He is also clinical assistant professor of gastroenterology emeritus at Oregon Health and Science University in Portland, Oregon, USA. He is board certified in gastroenterology and internal medicine and has diagnosed and treated over 7,000 patients whose symptoms were not explained by organ, disease, or injury. His book for patients, They Can't Find Anything Wrong, was praised by the president of Society for Biobehavioral Science and Medicine as truly remarkable. His podcast is called The Story Behind the Symptoms, where he interviews patients to find the cause of their pain or illness, much as he did in his practice for decades. Dr. Clarke, thank you so much for taking the time to chat with us today. I think this topic will be so helpful for so many people.
Thanks for having me, Ellie. I'm looking forward to it.
Yeah, it's going to be a great conversation, very relatable to me, relatable to, I'm sure, most women. Obviously, our podcast is geared towards women, but I think really anybody who's listening, whether you're a patient or a provider, you can glean a lot from this. So we'll just start by, if you can tell us how you got to this place, like how you started with gastroenterology and then moved into focusing on chronic pain.
Yeah, I wasn't supposed to be doing this. I was supposed to be a normal gastroenterologist, putting endoscopes in people and snipping things and cauterizing things and getting gallstones out and all those good things. And the first 7 years of my formal training, that's exactly what I was aimed at. I had no understanding, and it's kind of embarrassing to admit this, that uh, you could have pain or illness that was not caused by disease or injury, and that in fact, very real pain or illness could be generated by the brain pretty much anywhere in the body. The classic example is phantom limb pain, where somebody's had an amputation, but they feel pain at the place where the limb used to be. And of course, that's not coming from the limb because it's no longer there. It's generated by the brain. But the idea that that could happen in anybody, and that it in fact is happening in 1 out of 3 adults, and approximately 40% of people who go to the doctor, nobody ever mentioned that. So in my 8th year of formal training, I encountered a patient who was sent to us from another university. I was at UCLA at the time, learning to be a GI doctor. And they had done a thorough evaluation for this patient's very severe GI condition. They found nothing. We did some specialized testing, and that was normal. And it was left to me to essentially do her exit interview and say, I'm sorry, you're just going to have to live with this.
Yeah.
But we kept talking, and she shared with me that she'd been through a severe trauma as a girl. This had taken place 25 years in the past, so I didn't think it was related to her illness, which was only of 2 years duration. But I thought, well, that might have some significance. I'll send her to a psychiatrist that I know who has an interest in mind to body work, and maybe it'll help her live with her condition a little more successfully. And I forgot all about her until 3 months later, in the elevator ride that changed my career, I ran into Harriet Kaplan, the psychiatrist, in the elevator, and just to make conversation, I said, whatever happened to that patient that I sent you? And she said, oh, I haven't seen the patient in a couple of weeks now. She's cured. She's fine. Her severe problem, which, was averaging 1 bowel movement per month, was what her condition was, despite taking 4 different laxatives at double the recommended doses. And Harriet had cured her with less than 3 months of weekly counseling sessions. And the idea that you could do that you could alleviate serious, real physical symptoms just by knowing what to say to somebody and interacting with them and counseling them. Nobody had ever mentioned that such a thing was possible. So that was the start of my learning about this. I didn't think it was going to be something I would use very much. I thought, these cases must be rare, or I would have heard more about it.
Yeah.
Not true. 5 or 6 patients a week, 35% of my practice for decades, over 7,000 patients, as you mentioned earlier, that have this very real condition. And I kept going with it because even though I was a beginner in the early years, people were getting better. They
Mm,
were getting relief that they were not getting from the rest of the healthcare system. It was very rewarding for me personally as a physician. It's why I went into medicine, is to make people feel better, and they
yeah.
were. So I kept going with it and learned more and more. And up here in Portland, there were no Harriet Kaplans up here. Nobody else was doing this work, so I just took it on myself.
That's amazing. And yeah, it's got to be frustrating for the physician. It's frustrating for the patient when we can't find a reason for why we're having these symptoms. But, for a provider to be able to have both a reason and a treatment has got to be really encouraging. Is there a name for this condition, or is it something that is still kind of understudied?
No, there's probably a dozen names for this
Okay.
condition, but my colleagues and I had a long discussion a couple years ago and came up with neuroplastic symptoms, which we like because the neural part obviously refers to the brain and nervous system, which are physically changed in this condition. There's a real physical cause for this. It just happens to be in the brain instead of in the body. And the plastic term in medical jargon means a capacity for change. So we
Mm,
think that's very hopeful, that people who have this condition, even some who've had it for years or decades, people with multiple symptoms in many locations in the body, or symptoms that are very severe, can get better from this because of the brain's capacity for change. So we call them neuroplastic symptoms. My nonprofit is the Association for the Treatment of Neuroplastic Symptoms. Our website is symptomatic.me, and there's a 2 minute self-assessment quiz there that people can use to
oh,
check themselves out,
yeah.
if they think they might have this.
That's really interesting. It's interesting to hear you say that, because I think the skeptic in me and the skeptics out there, there's so much, especially on social media, that aims to kind of explain away symptoms or say like this is the treatment you need, and to hear you say that, it really shows just how real this is, and how there are real things happening in the brain that are causing these things to happen. I think that, I can be a little bit skeptical and say, like, okay, what is snake oil? What is real? What is actually studyable? And yeah, just in the research I've done, I was really surprised at just how many studies have been done to prove that this is a real thing that people are experiencing. There's a lot of science behind it.
Yes, there have been studies now from across North America. One of the ones that I love to quote is the Boulder Back Pain Study. They took 150 people with back pain for an average of 10 years, pain in their low back, their spine, and they divide them into three groups. One group got just their usual care, the same thing they'd been doing for 10 years. Another group got a big injection into the spine.
Mm,
It was a placebo. It wasn't like a
mm,
cortisone or anything like that. And the patients knew it was a placebo, but there's other studies that show that if you put a big injection into somebody's spine, it has a beneficial effect, yeah, even if
mm.
there's no active medication involved. And then the third group got one of the new neuroplastic recovery psychotherapies that have been developed in recent years. They're completely new and different from the usual kinds of psychotherapy that we can talk later about exactly the sorts of issues that they're going for there. But the outcomes were dramatic. The people who got this new form of psychotherapy, their pain scores, again, 10 years of pain on average, and they dropped by 75% in a month.
That's
All
incredible.
they got was, 2 hours a week for 4 weeks of this new kind of treatment, and the pain scores dropped by 75%, and many of them got complete relief. And then they've followed them up now, recent paper, for 5 years, and the pain scores are still down. I mean, it's
That,
just stunning. It is so far beyond older forms of treatment, whether it's drugs or injections or implanted devices or
mm,
surgery or um, any of these other forms of treatment, cognitive behavioral therapy.
mm.
They've all been tried. They all have modest benefits. This one just blows them all out of the water.
Yeah. I am curious, what is the treatment like? little background, my first child was stillborn. And so when I went through grief therapy, one of the things that my therapist did was brain spotting. I don't know if you're familiar with that. I don't know how popular of a treatment that is. And it was weird. Like so for anybody who isn't familiar, brain spotting is something where it's very similar to EMDR. You move your eyes and kind of focus on a point in the room, and then suddenly I was just bawling, and I had wasn't thinking about my child, wasn't even thinking about, what had brought me to therapy, but it was like those feelings were being processed. Is it similar to that at all, or is it completely something else?
We don't typically use brain spotting specifically, but
Mm-hmm.
there are some analogies there. The the simplest, most straightforward form of treatment is called pain reprocessing therapy, which is just a fancy term for shifting your attention from where it naturally wants to be, which is on the part of your body that is having symptoms,
Mm-hmm.
and just recognizing, look, you've had a diagnostic evaluation. Your body is not where the problem is originating. Like millions of others, your uh, negative diagnostic evaluation is interpreted to mean that your brain is creating this very real symptom in your body. So you need to shift your attention from your body to your brain and start to think about what might be going on there, what kinds of stresses, traumas, emotions, um, long-term impact of childhood adversity is another one. Other challenges in life. Start thinking about what some of those might be, and simultaneously reduce your fear level about your symptoms. If your body's been
Mm-hmm.
checked out and it's okay, you don't have to be afraid that you're going to be permanently disabled. You don't have to be afraid that your body has got some lurking issue going on in there that's going to cause massive serious problems for you. That's been evaluated. Start thinking about what might have caused your brain to undergo a bad neuroplastic change that's leading to these symptoms that we want to now provide with a good neuroplastic change back to a healthy pattern. So that's the first level, reducing fear, shifting focus, and that can have huge beneficial impacts on people. Because what the brain is doing here is it's trying to express that it is in a state of distress. It's actually trying to help you out. It's trying to tell you something about your life that it can't bring to your awareness any other way. You're not consciously aware of it. There's not any words you're able to put to it. It's kind of buried below the level of consciousness. So your brain is trying to, wave the red flag here by creating these symptoms and saying, there's something in your life that is not right. It may be from the past. With a very large number of my patients, they experienced adversity as kids, and that can have a long-term impact. The next level, if that alone doesn't bring the relief that we're looking for, then we have emotional awareness and expression therapy, where we are trying to identify issues in your life that may be creating emotions that you're not consciously aware of. In my first book, They Can't Find Anything Wrong, the very first story is a patient who was hospitalized at a major university 60 times in 15 years with no diagnosis. She was having attacks of severe dizziness and vomiting, and they would just come out of the blue, no obvious cause for them. And sometimes they would last for days and be severe enough she'd have to be in the hospital for intravenous fluid. Well, make a long story short, it turned out all these attacks were uh, connected to interacting directly or indirectly with her abusive mother, who had been abusing her verbally and emotionally since she was 3 or 4 years old and was still doing it. The patient was now age 50. So once we were able to show her these connections and that she had just enormous emotional tension and, to be honest, a fair amount of anger and resentment over what she'd been subjected to, once she could bring that into conscious awareness, then she was able to deal with it, to recognize it, think about it, write it down, and set some boundaries with mom so that mom could no longer have that same effect on her.
Wow, that's really interesting. So I found you through a post that you made about, it was specifically about women's pain being, you wrote, women wait an average of 65 minutes longer than men in the ER before receiving pain medication. They're more likely to be prescribed painkillers or sedatives instead of painkillers, and they're more likely to have their pain attributed to anxiety or emotional issues. And I mean, I can even relate. It was so funny because when I told my husband I was recording this episode, I was like, I don't really know if my pain's ever been ignored. And he looked at me and he said, what about our daughter's birth? And quick story. So when I had my daughter via C-section, I started telling the anesthesiologist, I'm feeling this. And she said, she was like, no, honey, if you were feeling this, you'd be screaming. And I couldn't really articulate where I was feeling it, but I was like, I am feeling this. And then fast forward to, she ended up giving me ketamine. And then fast forward to a year and a half later, I had my son. And I told that anesthesiologist, hey, I felt a lot of my last surgery, the last time I had a C-section. And he kind of was like, well, I don't know, it might have been anxiety. You might have been really, it was a very high stress situation. And then he looked back in my chart and he said, yeah, actually, she did not give you the full dose of anesthesia. And he said, I don't know why, because given your height and your weight, we would never give you less. But, it was really validating to then have my son and to experience a C-section with a full dose of anesthesia and really realize, okay, yeah, I was truly in pain. So kind of a long way to ask this question. Why do you think that is? Why is it that women's pain is typically ignored or is characterized as being a product of anxiety?
Yeah, it's clearly a situation of bias, either conscious or unconscious. Were the anesthesiologists men?
No. So actually, the surprisingly, the
Okay.
anesthesiologist who did not give me the full dose was a woman, and this anesthesiologist who looked back in my chart, I mean, and at first did tell me, "Oh, I think it's anxiety." That was a man.
Yeah, and I don't know where the bias comes from, but I can't think of any other explanation for this, and it certainly affects people of color as well, that
Yeah.
they tend to be given less pain medication and given it later as well.
Yeah.
And if you're not aware, by definition, if you have an unconscious bias, you're not aware of it. And the medical profession needs to have this, put in front of them so that they are consciously aware of it and can do a much better job of trying to compensate for that. Because
Yeah.
there's no excuse for somebody not receiving adequate pain treatment because of their gender or their skin color.
Yeah. And I think too, there's a difference between telling someone it's all in your head, it's anxiety, versus what you're saying, which is there is an actual problem. It's not that you're making this up, but there's an actual condition that is able to be treated. And so I think if providers, instead of just passing it off as anxiety and prescribing anxiety medication or telling them, you need to just relax and de-stress, but instead telling the patient, like, no, this could be what's wrong, and then referring them to someone who can actually treat it, that would be much more helpful as the patient. Being told it's all in your head when it really is an actual condition is different than being told, oh, you just have anxiety.
Yeah, and that's unfortunately the training of so many medical professionals, is that if your physical symptom is being attributed to anxiety or to depression or to being, quote, in your head, that is typically the end of the story for that
Mm.
physician. There is not recognition that, okay, if you're going to attribute it to those things, you need to take the next step and you need to find out why the patient has this. If you think it's quote unquote all in your head, that doesn't mean it's imaginary. All pain is real, in
Yeah.
fact. So that if you are saying this is brain generated, you need to take the next step and say, well, why is the brain doing this? What is going on in the patient's life, past or present, that is creating this very real symptom in them? And anxiety can create very real symptoms. In fact, probably a majority of people with an anxiety disorder are presenting themselves to the healthcare system with a physical symptom rather than
Mm.
a mental health symptom. Same with depression. There's research that shows that many people who die by suicide have a history of visiting their doctor within the 30 days before.
Oh,
And
wow.
what are they doing when they visit the doctor? Very likely they are visiting because of a physical symptom, and the doctor checks them out and doesn't find anything and doesn't take the next step. What is going on? And all too often, when you ask a patient in that situation, do you feel depressed? They will say no.
Mm.
They don't have that subjective sense of feeling depressed. They may feel stressed out, frustrated, exasperated, desperate to have you alleviate the physical symptom that brought them into your office. But most of them, in my experience, will say, no, not really feeling depressed today. So you have to dig a little deeper into the many other symptoms that depression can cause, which is things like you're not sleeping well, your energy level is down, your appetite is off, things you used to love to do no longer interest you, your sense of your life as having some purpose or meaning may have faded away. You may have had thoughts of harming yourself. You may be crying for no obvious reason.
Mm.
And when you ask people that series of questions, at least in my practice, I get yes answer after yes answer, and the diagnosis becomes very clear. One of my patients came very close to suicide the week
Mm.
before she was scheduled to see me for a second opinion. The GI doctor who was the first opinion had seen her 22 times in 7 months and never diagnosed her depression. And when she was in my office, she was crying through the whole visit. And he had obviously checked her out for bodily problems, and she didn't have any. She just had these vague symptoms in her belly that were quite distressing, but there was no cause for them. But she's sitting there crying, and I asked her all those questions I just listed, and she had, yes answers to all of them. And then when she could see the direction I was going, she told me the story about what she'd done the week before,
Mm.
which was she got up at 4 in the morning, feeling very much suicidal, put her bathrobe on, put a big brick in the pockets of her bathrobe on each side, drove to the Columbia River, which is this huge river that we have here, and walked out into it up to her neck and stood there for 10 minutes thinking about whether she was going to take the next steps and just go right on out into the river with her big heavy robe and the bricks. But after 10 minutes, she decided, she had this appointment with me and she was going to keep it. So she turned around, got back in her car, and drove home. And, she came that close.
Yeah.
And, the depression was as obvious as um, anything you can imagine once you ask the right questions.
Yeah. So, for those of us who haven't gone to medical school and who don't understand what the system of educating doctors and providers looks like, is there a thorough education in this and how to spot some of these like mental health issues or problems? And is that maybe one of the factors that could change systemically that would hugely benefit people who are experiencing this kind of pain?
Yeah, it not only benefits the patients, it benefits the doctors because,
Mm-hmm.
particularly in primary care, 40% of people who come through the door have neuroplastic symptoms. And physicians are typically not trained in how to evaluate them. They are trained in how to make sure you don't have an organ disease or structural damage. And then when they've ruled that out and the patient still has symptoms, they're not sure what to do next. The patients are very frustrated. The doctors are very frustrated. They These are patients that contribute to burnout by the physicians. But fortunately, we're finally seeing this start to change. I've been teaching in a physician assistant program for 30 years. I've been
Oh,
teaching for a number of years at my local medical school. I gave a speech in Spain about 15 years ago, and people in the audience were from a medical school in Slovenia, and they are now using my first book as a textbook. And they
wow.
invited me to speak to their national conference a few years ago. So it's there's starting to be recognition that these are patients that uh, actually have capacity for a successful outcome. If you know what to look for, if you can look for stress and trauma and emotions and the long-term impact of adverse childhood experiences and other challenges that people are having, including depression and anxiety, you can diagnose this as successfully, at least as successfully as any other condition, and treat it at least as successfully as any other. And the benefit of that, not only to the patient, it's obvious, but also to the doctors.
Yeah.
A family doctor who took the course on symptomatic.me and learned how to do this. She took me aside at a conference the next year and said, these ideas have put the joy back into my work.
That's really cool. That's huge. I have sort of a random question, but do you ever see patients who maybe have these adverse childhood experiences but don't remember them?
Yeah, it does happen sometimes, but most of my patients, they they remember if it was something bad, like my very first patient who was
Yeah.
sexually abused multiple times. To make somebody ill as an adult, usually they're able to remember what happened to them when they were young. But there are a lot of people who they remember it, but they don't think it was that bad
Mm,
because, none of us has a parallel life to compare ourselves with. So when my patients look back, they'll say, yeah, there was maybe a thing or two that happened, but it really wasn't that bad. I know other people who've been through worse than me,
yeah.
and I don't think it's affecting me today. So my response to that is to ask them to imagine their own child or a child that they care about if they don't have one of their own. Imagine that child growing up exactly as you did.
Mm,
And you are a butterfly on the wall of your childhood home, and you are watching your kid, the kid you care about, trying to cope with everything you had to cope with. How would you feel while you were watching that? Would it make you sad or angry to see that? And this completely reframes the perspective because people who look at their own life and say, no big deal. They think about it happening to their own kid, and it's like, no effing way.
yeah. Yeah. It's similar with, I heard this advice with self talk. Like, imagine saying the things that you're saying to yourself to your closest friend. Like, you would never say that to someone. So don't say it to yourself. But yeah, I think that is incredibly powerful. And I think it also, we can't live lives of comparison in that if you see someone who has gone through something and they seem to be fine or they are fine, that doesn't mean that the negative things that you've experienced don't don't have to affect you. Like I think that that's something that I myself have done of saying like, well, look at this person, look at everything that they've gone through, and they're living a successful and happy life. First of all, we don't know what's actually happening to them if
That
they
is
are
very
truly,
true.
yeah, like if what's really happening on the inside. And then secondly, just because they're able, it's sort of like pain tolerance. Like everyone has a different level, and just because something maybe is affecting you more or in a different way, that doesn't mean that it is not valid. So yeah, thank you for that. I think that is incredibly helpful advice. What advice would you give to a patient who, is kind of in the medical system? People, they don't feel like their symptoms are being taken seriously, or they have been trying to find the true cause of their symptoms and haven't been able to find it.
Yeah, well, if you've been in the system for a while and you've been evaluated diagnostically and nothing has been found. I mean, let's take this briefly from a statistical perspective. 40% of people who go to the doctor have got a neuroplastic symptom. If you go through all the diagnostic tests, your chances of having a neuroplastic symptom go from 40% to well over 90%. And so the next step is to do the diagnosis for that, which is, you can start with the self-assessment quiz on symptomatic.me. That's going to give you some clues depending on the number of yes answers you have to those questions. And then, if it looks like this is uh, it got any chance at all of being a possibility, start using some of the treatment resources that are available and see if you start to make progress. See if the treatment resources resonate for you in terms of the value that they're providing for you. And if you begin to improve in response to treating the underlying stress issues, past or present, that's pretty solid evidence that you are on the right track, that you are on a healing pathway that is eventually going to produce relief of your symptoms. So, using the treatment resources is both diagnostic as well as therapeutic. And I should add here that just the kinds of symptoms that can benefit from this approach. Again, I mentioned earlier from head to toe, but migraines, visual disturbances, ringing in the ears, dizziness, facial nerve problems, pain in the temporomandibular joint of the jaw, pain in the spine, fibromyalgia, irritable bowel, pelvic pain, genital problems, bladder spasms, certain kinds of rashes, joint pains, chronic fatigue, condition. There are a lot of clinicians out there who will blame these symptoms on various things that are not really the cause of them, like Ehlers-Danlos or hypermobility or
Hmm.
chronic Lyme or a condition called POTS or
Yeah.
MCAS, which is mast cell activation syndrome. A lot of symptoms get blamed on that when 95% of the time or more, it's not MCAS. So um, all of those kind of things, and especially if you have more than one at the same time, very likely to be neuroplastic. If the symptoms move around, that's likely to be neuroplastic rather than symptoms that are stationary. If they're highly variable symptoms, if they seem to get uh, triggered by inconsistently. Um, so all of those are clues that a neuroplastic condition is going on, which is great news because we can diagnose and treat it successfully.
Yeah. And then if someone does get, meets those criteria, do they then find a provider that's near to them? Do they try to do it remotely? Is it kind of just based off of the patient and their needs?
Yeah, everybody's different, but there are many people who can have success with treatment on their own using the resources that are available. We have
Cool.
videos. There are all kinds of self-help books, including my own, but many others that are based on the science in this field. There are apps now. The Curable app, the Nirvana app, the Digestible app for people with gastrointestinal symptoms, the Freeme app for people with chronic fatigue.
Mm.
Long COVID is would be another one that the
Mm.
Freeme app would be good for. Then there are podcasts that my colleagues and I have done that are available at symptomatic.me. My own, you mentioned in the intro, I interview people who have had these conditions and try to pull out the events and stresses in their lives that were
Mm.
responsible, and people get a lot of insight from those. I got a lovely note from a woman in Europe who said she'd had pelvic pain for 28 years, and she watched the first 10 of my podcasts and no longer has pelvic pain.
Wow. That's incredible.
And then, if all of that is not sufficient, then we have a directory of practitioners who have taken extra training in this field, and they are all over the world. And many of them will see people remotely, so that even if you're in a location that doesn't have a physically located practitioner or coach, many of them will see you um, via the internet.
Yeah. How prevalent is the awareness of this? Is it something that people from the provider side, are providers still pretty unaware of this? Is this something that would benefit from sort of a like awareness campaign, or maybe something more top down where there's more education, or I can't remember the name of it, but education after receiving an MD? Like what would
Continuing
be
medical education.
yes, thank you. Is that something that this would be that people would benefit from?
Yeah, it's the whole purpose of the nonprofit,
Yeah.
the Association for the Treatment of Neuroplastic Symptoms, is to educate medical and mental health professionals and the public about this. And we're getting more and more traction as the research gets published. These concepts are more and more difficult for the skeptics to ignore,
Yeah.
especially when the results have been so astoundingly good. The UCLA study, they compared the new kind of neuroplastic recovery therapy with the standard old school cognitive behavioral therapy, and
Mm.
a very tough group of older male veterans with chronic pain. This is a group that is not going to take any psychobabble from you. They're just
Yeah.
going to walk away if you try to throw anything at them that isn't speaking to them. And they tried to get at least 30% pain relief was their goal.
Hmm.
And in the cognitive behavioral therapy group, 17% made it to the goal, which is not very good, but it's typical for what you get with CBT. In the group that got the new emotional awareness and expression therapy, 63% made the goal. So, fourfold almost a greater improvement. The results have just been astounding. And as these studies get published, more and more healthcare professional schools are incorporating it into their curriculum. More and more professionals are including it in what they offer to their patients. So we're rapidly approaching a tipping point.
Yeah, that's really encouraging because I can imagine I mean, with any, I did advocacy in the stillbirth prevention space. And in that, we got a lot of pushback of, well, stillbirth can't be prevented, or, well, and just it seems to be that when there is an idea about this is the way things are, and when you want to counter that idea to say, well, no, actually, like, look at this research, look at studies from other countries, look at these interventions that have truly saved lives, there still seems to be a pushback. And I don't know exactly where that comes from. I don't know if it's just skepticism, or if it's the sense I get is that there's almost a defensiveness of, oh, well, if you're saying that this can be prevented, or that there's a treatment here, then that means I wasn't doing the right thing, which is not at all what we were trying to say to providers. But yeah, we had a lot of pushback from ACOG, the American College of Obstetrics and Gynecology, because there wasn't enough research into this intervention we were advocating for. And yeah, it's frustrating to me because things are always advancing, they're always developing, we're always discovering new things. I guess the question I want to ask you, I'm not being very articulate here, is what is the reason for the skepticism and the pushback, and how do we sort of counter that culture in our own minds? Like, how do we open ourselves up to more ideas? while still having a healthy level of skepticism, I guess, to not being swayed by things that aren't scientific or are people just kind of financially benefiting from other people's pain.
Yeah, you definitely have to show people the evidence
Yeah.
that this approach is highly effective, but it's natural in the history of science of any new scientific idea that there's resistance to it from people that are accustomed to working and thinking in a particular way. In my field, it's particularly a challenge because medical professionals were trained in organs and structures. And now
Mm,
all of a sudden we're telling them that 40% of their patients, it needs psychological thinking to understand what's going on. And this is a completely different um, exercise intellectually for people to do who are, trained as physicians. And you're also pointing out that it means that they've been missing the real cause of their patient's illness for most of their careers. And that's, not a happy idea either. A classic example in medical profession having to do with obstetrics was a doctor named Semmelweis in Vienna in the 1840s who through observation, noticed that the death rate after birth of the mothers was much higher if the mother had been, if the babies had been delivered by a man, by
mm,
an obstetrician, as opposed to a midwife.
mm,
And he, through observation, discovered that the midwives were washing their hands after deliveries, and the obstetricians were not. And so he recommended that the obstetricians wash their hands between deliveries, which you would think would be especially with the data that he developed, a non-controversial concept. But uh, the obstetricians resented the idea that he was implying that they were responsible for the deaths of their patients. And they ostracized him from their medical community, and he ended up in an asylum where he was beaten and died within a couple of weeks. So, uh, a horrible story about somebody who was trying to do the right thing medically, but it illustrates that resistance that people have. So what we advocate is collaboration with a
mm,
behavioral health clinician. We advocate integrated care where a mental health or behavioral health professional is right there in the primary care office. And if I am seeing a patient who has a neuroplastic condition, they don't have to leave the office. They don't have to leave the exam room. I just
mm,
bring the behavioral health clinician in and I say, I've got a stress expert here that I want to interview you to see if there could be anything in your life, past or present, that could be contributing to this very real symptom that you have that is not coming from your body.
mm,
And that's been found to be very well accepted. The doctor who said that these ideas had put the joy back into her work was using exactly that model.
mm.
And all of a sudden, the 40% of her patients who used to make her beat her head against the wall were now a source of joy because they were getting better.
Yeah. Thank you so much for answering that rambling question that I gave you.
Well, I gave you a rambling answer.
No, it was perfect. Yeah, I mean that was exactly kind of what I was hoping you would answer. And I think that to any of the providers listening, I think that's the message to take from this is that no one is bringing condemnation or judgment. It's hey, we are learning now that this is the or we have learned because you've been in this for a much longer time, but there's new information and so now there can be new practice and it's not bringing judgment or anything onto anybody. It's just hey, there's new opportunities and how great would it be to be able to give your patients a life free from the pain that they've been suffering from for a long time. So yeah, with that, what advice would you give to a practitioner who is listening or a provider who's listening?
Well, the question I get most from medical clinicians that I teach about this, and I've been teaching about this since I gave my first speech on this to medical clinicians in 1985. So I've been doing it for a long time. And the most common question is, how do I talk to a patient about this in a way that they won't want to throw me out of the room?
Yeah.
And the answer is that I bring this up right at the very beginning as just
Mm.
one, that neuroplastic conditions are one possible cause of a person's symptoms. So if they've got upper abdominal pain, for example, I'm going to be asking them, or I'm going to be saying to them, well, it could be an ulcer, it could be a gallstone, it could be your pancreas, or it could be brain generated pain from stress. And those are all equally real. And we're going to check you out for all four of them. And, we're going to do an endoscopy and an ultrasound and some blood tests. And at the same time, we're going to talk to you about, are you having some stresses in your life right now? Is it possible that the onset of your pain coincided with a stress that began in your life? One of my patients, that was the answer right there. We didn't have to go any further because he only got his pain when he was driving to work.
Mm.
When he was driving home from work, he was fine. Which your belly doesn't know which direction you're driving. Only your brain knows that.
Yeah.
And so the obvious next question was, well, what's happening at work? And there was a huge stress in his workplace, and the stress had begun right before his symptoms began. So there was that coincidence in timing as well.
Yeah.
So this empowered him to go back to a supervisor and say, look, we got to make some changes here. And that happened and his pain went away.
Yeah.
It's just the simplest example, but you have to have that orientation of looking for that as a equally valid cause for pain as ulcers, gallstones, and pancreatitis.
Mm. Yeah, that's really interesting. So this reminds me when my mother-in-law passed away, which was almost 3 years ago. My husband had really horrible back pain immediately after.
Mm.
In about a week after, he started saying, "Man, and he was doing stretches and trying to alleviate it." And I said, I think it's the stress of losing your mom. But in my mind, it was, when we experience stress, I thought we hold like the tension, and I thought it was him kind of holding himself differently. But now thinking back, it makes sense that it was more brain related than necessarily his body positioning or adding tension. And obviously, I'm not a doctor or a physical therapist, so I can't really diagnose him, but I'm just remembering that. It was really interesting.
Yeah, it's astounding to me the level of severity that the brain can produce in the body.
Mm.
In terms of duration, in terms of number of symptoms. One of my patients had 27 different symptoms simultaneously.
Wow.
Another patient of mine had unexplained abdominal pain for 79 years. And she was a nurse, so she got plenty of medical attention,
Yeah.
and they never found anything. But it was all related to a trauma that happened to her when she was age 8.
Wow.
Another patient I was asked to see this is a teenage girl uh, who had been in the hospital for 10 straight weeks, 70 days, and she was getting massive doses of morphine around the clock for unexplained abdominal pain. And I'm going through the records, and she has seen 6 other gastrointestinal specialists over the
Mm.
previous 18 months with no diagnosis. Um, and another patient, again, just to cite how extreme this can be, his stomach, the organ of digestion, not the abdomen, but the actual
Mm.
organ, was paralyzed. He was admitted to the hospital because he couldn't keep anything down and he needed intravenous fluids. And we looked at his stomach with an endoscope and it was fine.
Mm.
Then we tested it with a nuclear tracer to see how rapidly it was emptying. We know how rapidly it's supposed to empty, and his was not emptying at all. They called me from the tracer lab, and they said, we've been scanning this guy for 2 hours, and the tracer is still sitting there. It hasn't moved at all, and it should have been more than half of it should have been out of there by then. And they said,
Mm.
how long do you want us to keep scanning him? And I said, his stomach is paralyzed. You can stop. And it was all of those patients that I just mentioned, it was neuroplastic because when we uncovered the stress and treated it, they all got better.
Wow. That's so interesting. I took a human anatomy class a couple semesters ago, and I was fascinated by just the anatomy of how pain receptors work and where it is. But I think if we get into that, it's going to get a little too long. So we'll edit
Well,
this out.
I can tell you that when it comes to those receptors, let's say you whack your thumb with a hammer,
Yeah.
you don't get a pain signal from your thumb. It feels like you're getting a pain signal, but you're actually getting a damage signal. And it goes up
Oh,
to your brain, and your brain has to decide, am I going to give you a pain signal so that you'll be aware that your thumb is damaged so that you'll take good care of it? And most of the time, that's exactly what it's going to do. It's going to give you a pain signal right away, and you're going to start paying attention to making sure you don't damage your thumb any further. But it is a choice by your brain to do this. And there are other times when it makes different choices. So let's say that you are running from a predator and you
hmm.
sprain your ankle. Your brain is going to decide, you know what? You don't need a pain signal right now. Um, you need to get away from this predator. And once you're in a safe place, then you can have the pain signal. Then it's going to make sense. Um, and we see that all the time in people with who are wounded in military combat. They
Hmm.
don't necessarily feel the pain from the wound until they reach safety, and they're in the um, mobile army surgical hospital, and that's when the pain begins to take effect. Another example, very famous in my field, was a construction worker who jumped down from a platform and impaled his boot on a nail. And I should get a little prop to show you what that looked like. The He was instantly in agonizing pain because the nail went through the bottom of his boot and came out the top. And he was rushed to the emergency room. He was given morphine intravenously to alleviate the pain. And then they carefully cut the boot away, only to reveal that the nail had passed neatly between his toes. And he did not have a scratch. So as soon as he saw that, pain went away. But it's an example of how your brain will take the information that is coming to it. Your brain is sitting there in a warm bath in a very dark place, having to rely on the signals it gets from the outside world to make decisions. And in that case, um,
That is crazy.
made the wrong decision.
That is really incredible. Yeah, I remember as a kid, I went to one of a local science museum, and they had a thing set up where you would put your hand somehow underneath this fake arm, and after a period of time, you would stroke the arm, and your brain would feel it on your hand. It was really crazy, and I think as a kid, I was just like, "Oh, this is a cool trick," but thinking back on that, it's pretty amazing to see what the brain can do.
Yeah, it's doing the best it can with the information that is provided to it,
Yeah.
and it gets signals from inside the body as well as the outside. The classic when you whack your thumb, but it gets internal signals as well, and it can misinterpret those, and
Mm,
it can also send signals down um, into the body that create problems that. Um, you don't have if you're not subjected to stress.
yeah. What would you say to the system level? What would be one of the main things that you would change either about the medical system or the education system for doctors that would direct people to this condition?
It really starts with one simple concept. Most people assume that if you've got pain or illness, you must have an injury or a disease to
Mm,
explain it. But it turns out that assumption is wrong. That you can have pain or illness every bit as bad as those from any other cause generated by the brain because of stress, trauma, adversity in childhood, unrecognized emotions, like the emotion you had when you were doing the brain spotting, the
mm-hmm.
emotion that just came out of nowhere. So
Yeah.
many of my patients, they have those emotions. They're just getting expressed via their bodies. And it can be, other challenges in life as well. And it doesn't have to be really obvious childhood adversity. It can be just pressure to control your emotions,
Mm.
pressure to perform, subtle indications that you're not measuring up. Those can have the same long-term impacts as more abusive experiences. So I would love for both the medical profession and the public to be aware of these, very basic ideas, because that would change everything. People would then know that if their bodies check out, where to go next. We wouldn't be writing off people as saying, you know what, this is stress, this is anxiety, this is in your head. We would take the next step and find out why uh, is it being generated by your brain, because symptoms always happen for a reason.
Mm. That's great. And I think that's so validating to someone who has been experiencing chronic pain without an answer, just to know it's happening for a reason. You're not making this up. I think that's a very empowering thing for people to know.
Yeah, so many of my patients have been made to feel like they're going crazy because they've
Yeah.
got these incredible symptoms. They know that they're real, and
Mm.
nobody can find anything. That's the title of my book. They can't find anything wrong.
Yeah.
And it's so validating to know that, yeah, you have a real thing.
Yeah.
And it is not rare. It's, 1 in 3 adults, according to our national survey from last year.
Wow. Well, thank you so much for coming on this podcast, explaining this, giving people those resources. Where could people find you?
Well, the ATNS, a nonprofit, founded and led by volunteers, we're not doing this for the money, is at symptomatic.me. And a good place to start is with the self-assessment quiz. And there are lots of resources there that are strictly based on the science. And people can just start using those, um, whichever ones resonate for them, and see if they start to make progress. And most of the time, if they've got a neuroplastic condition, they will.
Thank you. I'm going to take the assessment just because I'm thinking of some things that I am like, yeah, we're gonna check that out. Um, well, thank you, Dr. Clarke. I really appreciate your time and I appreciate you coming on and chatting about this. Thank you, everyone, for listening. You can find more about the Determinants of Her Health podcast on our Instagram, which is determinants.pod. And you can also email me at determinantspod@gmail.com. I hope you all have a beautiful and healthy day.